Today's webinar, Law Enforcement Phlebotomy Programs, hosted by Responsibility.org and the National Alliance to Stop Impaired Driving. I'm Darren Grondell, the Vice President of Government Relations and Traffic Safety at Responsibility.org. I will be your host for today's webinar, highlighting law enforcement phlebotomy programs, the National Highway Traffic Safety Administration's phlebotomy toolkit, and successful implementations. Just by way of background, I previously served with the Washington State Patrol for over 25 years and with the Washington State Traffic Safety Commission for over 8 years. I'd like to give a special shout out to the amazing staff at the Washington Traffic Safety Commission who were really an inspiration for me for this webinar, who had the courage and the tenacity to help Washington State build a phlebotomy program in Washington State. Our program managers there were Etika Escada and Mark Nadalin, and who worked tirelessly with the Lakewood Police Department in Lakewood, Washington. They really were pioneers in making this program work. It was a significant pioneer, or I should say a paradigm shift, and we appreciate their work. I'd also like to give a special thanks to Chief Mike Zorro of Lakewood Police Department and Sergeant John Frazier for their leadership and changing the paradigm of phlebotomy in Washington to address the ongoing issue of multiple substance impaired driving. Washington now has close to 12 agencies and 66 officers who are now trained in phlebotomy. So just by way of a few housekeeping items, mics are muted. Please provide any questions or comments in the chat box, and we will get to those in a question and answer session here in the presentation. We will be doing some polling questions in the presentation, which will help identify some of the insights that we will hope that you can address and support with. So don't worry, the data is anonymous, and we are hoping that this data will just help support you. The Foundation for Advancing Alcohol Responsibility, or responsibility.org, is our namesake, and we are committed to responsibility. Founded in 1991 by the leading distillers, we have invested over $300 million in policy development, educational programs, public awareness campaigns to fight drunk driving and underage drinking. And as part of our threefold mission that's here, leading efforts to eliminate, not just prevent or reduce, but to eliminate drunk driving and working with others to end all impaired driving. Hence, our partners today working together to help eliminate impaired driving. We have become a national thought and action leader, continually seeking ways to collaborate with key partners to address the pressing needs to address impaired driving. As you may know, driving under the influence is the only crime where we generally collect minimal evidence and then submit criminal charges. We need to change that cultural perspective around impaired driving and begin to investigate arrests, gather evidence, and toxicological screenings from 360 degrees. You know, data, as you look at, it really helps drive the narrative. In today's world, data drives that. And as you see here, 50% of fatally injured drug positive drivers with a known drug test result were positive for 2 or more drugs. And 40 or almost 41% of the time were found to have alcohol in their system. Among drug positive drivers in crashes, 4% tested positive for both marijuana and opioids, 16% for opioids, and only 30%, and then 38% for marijuana, which we also see is coming up, and 40% of other drugs. So really, this is a pressing issue and a need to be able to gather good evidence, especially in polysubstance cases. Well, so today we will be sharing some data with you. So take a look at some of the data slides that will be coming up that will be addressing some of the issues, some of the priority and policy, practice, funding, and training. This has been a problem for a long time, the multi-substance issue, and it is time for us in the criminal justice arena to change our paradigm on how to collect blood evidence in these types of cases. If you always do what you always have done, you always get what you've always gotten. So today, really look at where you're at as a state. Even if you do have phlebotomy programs in your state, how could you enhance and improve those systems? So this will be our first polling question. If you take a quick second and answer these questions, do you have an existing law enforcement phlebotomy program in your state or agency? Okay, we'll close the poll. Take a look at some of the data. That's exactly why we're holding this seminar, or this webinar. Really is 67% said no. 5% said it was within their agency, 8% within both the state and the agencies. So hopefully today you can take away some key issues on how to help build your phlebotomy program. Our next poll question, we'll close that. Our next question is, how is blood evidence collected in your state? This is multiple, so you can choose all that apply. Go ahead and take a few seconds to fill that out. Okay, Katie, let's see the results on that one. I hope everybody had a chance to fill that one. Another reason why we are having this webinar is looking at the data is seeing that 91% of those are either drawn by hospitals, doctors, or nurses. And for us in the law enforcement arena, you know how difficult that can be when you get to court and try to get the doctor or nurse to come in and testify. Law enforcement phlebotomists, 28%, which is good to see. Jail, contract phlebotomists, EMT, and other. So very good information to kind of see what is happening around the country. And I will add, we have over 372 registrants for today's webinar, so showing a lot of very particular interest in this topic. So today we have, we're pleased to be joined by Jennifer Davidson, a highway safety specialist with the National Highway Traffic Safety Administration, and by retired Lieutenant Don Morose from the Minnesota State Patrol. He was a DRE and is now serving in the role of a consultant. In my previous life in Washington State Patrol and the Washington Traffic Safety Commission, I had the distinct pleasure of working with both of them on a variety of national committees, projects, and programs. And so it's an honor to be able to host with them today. And today I will now, or actually now, I will turn it over to Jennifer Davidson.
Thank you, Dr. Grandel, and thank you, Responsibility.org, for your support of this important issue and for your partnership in reducing impaired driving. And thank you to all of you for joining us on the webinar. It's a huge turnout, and for the life-saving work that you do on a daily basis to reduce impaired driving, crashes, injuries, and fatalities. So thank you for keeping our roads and communities safe. At NHTSA, our mission is to save lives, prevent injuries, and reduce economic costs due to road traffic crashes. And we do that through education, research, the setting of safety standards, and enforcement activities. And I wanted to note that for decades, NHTSA has been engaged in numerous activities to reduce impaired driving, including conducting research, developing policy and resources, programs, and helping to share some of those best practices within the states to assist in the local communities. So thank you. The turnout for this webinar is really indicative of that huge effort in collaboration on impaired driving. So what are the numbers telling us in terms of impaired driving? The recently released Fatality Analysis Reporting System data showed us in 2019, we had 36,096 traffic fatalities. And there's a little bit of good news here. This was a 2% decrease in the fatalities from 2018, which were 36,835 fatalities. Our alcohol impaired driving fatalities accounted for 28% of those overall numbers, totaling 10,142 deaths. This was a 5.3% decrease, so we did see a downward trend and it was good news. However, I wanted to share with you some findings that we saw in 2020. And Darren, if you can go to the next slide. We recently released two special reports. The first one was in October, looking at an examination of the traffic safety environment during the second quarter of 2020. And most recently in January of 2021, we also released third quarter data from 2020. And we did see some concerns that these numbers were trending in the wrong direction, including other risk factors. So I wanted to share some of this information with you today. Both of these items are available, and I can post a link and make sure that Darren has the reports available for you so you can access them. But I did want to share some of the impaired driving related data or prevalence information because it really helps set the stage for the importance of the work that we're talking about today. Next slide, please. So just to look a little bit further into this, we saw our traffic fatalities in the first and second quarter go down in 2020. So in the left-hand column, you'll see the yellow bars. We do have, it's not as concerning. However, when we look over at the fatality rate, this is where we had a lot of concern because it jumped significantly and we weren't where we wanted to be. So the fatality rate per 100 million vehicle miles traveled in that right-hand column, it increased substantially during that second quarter of 2020 from 1.10 to 1.42. So we really wanted to understand why, and we started to look at other data that was coming in. And it's important for me to note that this data is not conclusive, but it does give us some important information to take note of. So in order to understand why, we started to look at the information on a monthly basis. And again, 2020 is listed in yellow, and on the left-hand side, you'll see our fatalities. COVID started around March and we had our stay-at-home orders and people social distancing and not out on the road as much. In April, our numbers did go down, but they started to climb in May and June. And you'll see again, there's a large spike in the fatality rate over in the right-hand column. Next slide. So moving on to what we were expecting and hoping to learn. Sometimes when you have a situation like this, it's helpful to look back at a historical context and kind of see what the data has told us in the past and how it might react in the current time. And in a normal recession, when our BMT is down and the unemployment numbers are up, we generally see that there's less disposable income and our alcohol and other risks would be down as well as the fatalities. But the second quarter of 2020 was not behaving this way. Our BMT was down and our unemployment numbers were up. However, we saw alcohol and other risks go way up while our fatalities remained flat. So this was very concerning and we needed to figure out really what was going on. In the next slide, we'll take a look at the VMT. So you'll see starting in April, May, and June, the VMT started to go back up. People started to emerge from their homes a little bit. We had about a third of the population during that time starting to go out to work if they were essential employees, but also we did notice that uptick in some of these risky behaviors that I'll share with you. And next slide. During that time, we did see that traffic enforcement changed substantially. And unfortunately, I'm very sad to announce that now more than 350 first responders have died from COVID-19. Law enforcement comprised of 2/3 of the first responder fatalities, and this is just a tragedy. We know that the enforcement environment changed at least through the middle of 2020, where many law enforcement agencies had policies kind of limiting interactions for social distancing with the public and safety concerns. We saw reductions in traffic stops, DWI arrests, and speeding citations and belt citations, and a little bit less involvement in high visibility enforcement efforts. So this kind of just lays the landscape for what we were seeing. And when we try to understand who was responding to this lack of deterrence and what behaviors it might be affecting, I did want to share on the next slide kind of what we were seeing in terms of alcohol and other drugs. We did see through some of our data that there's an increase in opioid-related EMS calls and naloxone administration centered around opioid overdose, and this was more pronounced in urban areas. We also saw a documented increase in marijuana sales through taxes that were reported, and alcohol sales were at an all-time high, as well as self-reported self-medication. And we had a trauma center study, which is also available, and I'll make sure you have a link to that, which did indicate an increase in the prevalence of alcohol and other drugs among critically injured road users at 5 trauma centers. So looking a little more closely at some of that information on the next slide, you'll see on the left-hand side, I mentioned the increase in EMS activations related to potential opioid overdose, and you'll see the green line is our 2020 numbers. So those calls were at a much higher increase over 2019 numbers, and particularly starting in week 12, 13 of the year of 2020, it started to go up even higher. We had documented increases in drug and alcohol use. As I mentioned, there were wholesale and retail sales of alcohol were at record levels. States that reported their marijuana sales revenues showed dramatic increases throughout the quarter, as high as 40% increase in sales. On the left, we mentioned the significant increases in EMS calls related to opioid overdoses, and surveys showed us self-reported increases in alcohol and other drug use, particularly for 18 to 34-year-olds. So even though we had some decreases in our numbers for 2019, there's strong data that's coming in and showing us that the prevalence and use is higher for 2020. So we need to keep an eye on that. We did have a study in the field that I mentioned, the trauma study. We were able to kind of pivot this study and really see what's happening. And beginning in September 19, we were collecting random samples of fatal or near fatal crash victims from 5 trauma centers along the East Coast of the United States. And we started analyzing those samples. And overall, we found that 51% tested positive for alcohol or some other drug from September 19th until mid-March of 2020. After mid-March of 2020, 55% tested positive for alcohol or other drugs. And among those, you can see on the slide that alcohol went from 21.8% to 28.3% after March. Cannabinoids went from 20.8% to 32.7%, and opioids jumped from 7.5% to 13.9%. Next slide. So I did want to share some of that information related to impaired driving. However, there are other risk factors included with important findings on increased ejections and less seatbelt use. So I do highly recommend that you take a look at that special report from October and then also the newly released 3rd quarter data. But all of that really helps us to, underlie the importance of the work that we're doing is so important to reducing impaired driving. And we know that law enforcement, particularly impaired driving enforcement, is critical to identify, detect and remove those impaired drivers from our roadways, hopefully to reduce those crashes, reduce injuries and fatalities resulting from them, and to identify people who may need to be matched with other services like treatment when needed. So law enforcement phlebotomy programs can help to kind of assist law enforcement in working through impaired driving stops. And if we can go to the next screen, I believe we have our first polling question in this section. So on average, how long does it take to obtain blood after getting the search warrant in minutes? Take just a minute and let us know on average what you're seeing in order to collect blood evidence. Okay, let's close the poll and see where we're averaging here. Okay, so on average, we're seeing about 41 to 90 minutes. 34% of you had mentioned that it takes 41 to 90 minutes. 29% said 15 to 40 minutes. And then our next largest is 91 to 120 minutes. So law enforcement phlebotomy programs can really help us to reduce those times and reduce costs. They allow law enforcement officers with specialized training to draw blood for investigative purposes. They allow for the collection of chemical testing evidence in a timely and efficient manner. As we saw on the screen, I expect many of those in the lower category already have existing law enforcement phlebotomy programs, and we know collecting this evidence in a timely manner is particularly important for our drug impaired driving cases. And it can be a proven strategy to mitigate time and cost issues associated with drawing blood from drivers suspected of DWI. We currently have about 12 states. We have 12 states who have active law enforcement phlebotomy programs, and we're continuing to see that number rise. So it's very encouraging. Next slide. We have another polling question. What challenges do you face in implementing a phlebotomy program? And this one, you can select multiple answers, so please select all that apply. Okay, let's close the question and see what challenges people are facing. Funding to begin the program. And then we also have chief authorization. It looks like we're pretty equal across the board. So funding, council authorization, chief authorization, training locations, and prosecution support. So these are all challenges that can definitely be encountered with law enforcement phlebotomy programs, and we do have some resources to help you with them. So on the next slide, I would like to share with you one of those resources. We do have a law enforcement phlebotomy toolkit. This was developed in partnership with many of you on the line, working through a task order with Toxel. And this law enforcement phlebotomy toolkit is available now on the NHTSA website. You can go to NHTSA.gov and do a simple keyword search for phlebotomy, and it will bring you directly to this law enforcement phlebotomy toolkit, or we do have the expanded link listed below. But this toolkit really is a comprehensive guide to help assist law enforcement and state agencies in the establishment of new programs. And it includes really helpful content, including understanding the need for the importance and the benefits of law enforcement phlebotomy programs, how to plan and implement a phlebotomy program, and it's everything from case law, policy development, legislation considerations on whether there might need to be a legislative change within a state to kind of identify or define who is eligible within a state to draw blood. It includes training recommendations and considerations, how to address liability concerns, as well as obtain buy-in from stakeholders, some of the barriers that people can face, including the ones that we just saw on the previous screen, and how to overcome them, as well as costs for not only establishing a program, but also the cost benefit analysis and the money that can be saved and time that can be saved in implementing a law enforcement phlebotomy program. Utah Highway Patrol reported that they saved $30,000 in the first year that they implemented a law enforcement phlebotomy program. So these are huge time and cost savings that can be seen. And the toolkit also includes tips for implementing and sustaining a successful law enforcement phlebotomy program, as well as additional resources and contacts, so that states who have existing law enforcement programs can be contacted to help with others who are interested. And I am very excited to also announce that there is going to be additional support. We just awarded an additional task order to Toxel to provide financial support and technical assistance to states who are interested in establishing or implementing a law enforcement phlebotomy program or strengthening an existing program. So this is an active task order, and it's currently in the application development process, and please be on the lookout soon for an announcement on the eligibility criteria, the application process, and additional information on how to be connected to that. I did provide on the next slide my contact information. I do encourage you to please reach out with any questions, and please feel free to send me an email if you're interested in making sure that you're included in the announcement when it goes out for the financial support and technical assistance. I can connect you with Toxel, and we'll make sure that you are included in that announcement. I just want to say again, thank you for the life-saving work that you do on a daily basis to keep our roads safe, and for your interest in this issue. And it is my pleasure now to turn it over to retired Lieutenant Don Morose, who will share with you his experiences in establishing and supporting law enforcement phlebotomy programs. Don?
Thanks, Jennifer. I really appreciate both responsibility.org and NHTSA inviting me to be along with you here today to give you a little bit of insight on what I did when I was still working for the State Patrol in Minnesota to build our program. I'm going to talk about a couple of the things that I did and kind of how I rolled things out. And obviously everybody's experience is going to be a little different, but we'll talk about some of the general things that people are going to run into, things to think about, things to maybe keep in your back pocket, be ready for as we start to roll out our programs. My contact information on the screen there, if there's anything that I can do to assist you on that as well. I worked on the toolkit that Jennifer just mentioned, so I've got a little bit of background in that as well. So some of the things that I'm going to talk about today come from my time working on that project as well. So first thing I want to talk about, we had a poll question just a couple of minutes ago about some of the things that might be hindering that phlebotomy program in your state or agency, and funding was the biggest one on there. And we just heard some of the data that Jennifer just mentioned about some of that cost savings. And I know it's a tough argument sometimes, but it potentially can be self-sustaining. The money you save on maybe on the back end for court and paying contract phlebotomists and some of those other things can be used on the front end to train officers, troopers and deputies to be those law enforcement phlebotomists. So that's an argument there. That's a way maybe to present some of those things. And in that poll question, we heard a couple of those hindrances. There's a few more on here. Certainly there are all kinds of roadblocks and stumbling points along the way that you might experience that we maybe not even thinking about here. And a couple of comments came in after that poll question about the law. The law is the biggest hindrance. And I will touch on what I did or what we had in Minnesota and kind of how we worked around that, or how we worked within the current law to allow for those law enforcement phlebotomy folks to be trained. So the first one on here that I personally experienced in Minnesota was that kind of perception of liability. And that wasn't, that was the biggest comment, I guess, I heard from individuals when I started talking about this and trying to develop the program in Minnesota. It's like, well, what's the liability? What's the liability? In the back of my brain, I thought, well, law enforcement's a very highly liable or liability prone program profession. So part of me was like, well, we experience those potential things every day. And if you do what we do in firearms and defensive tactics and emergency vehicle operation and all the other things, plan well on the front end, do the education on the front end, it certainly reduces the liability on the back end. And I will show you what we have in Minnesota law here in a moment as well, that helped us kind of defeat that a little bit. It still was in the back of folks' brains, even when I showed them that the statute allowed for it, and they still went, yeah, but, and I'm like, okay. I mean, people warm up to it, people come around, and that's great. Another argument was, well, we have those practitioners in other professions. We have doctors, lawyers, nurses, or excuse me, doctors and nurses and med techs and those folks that can do that. Why should we train our own folks? And again, the time saving and the cost saving and all the other pieces that go along with that is a good way to kind of argue those things as well. The argument is, well, it's not really a law enforcement function, to which I said, well, yeah, it really is. It is evidence in a criminal or civil case. And to ask, and from here on out, I will use the term nurse as a generic term for anybody in the medical profession that can draw those, just so I don't have to keep repeating myself, but asking that nurse to thrust themselves into that criminal investigation, become a criminal witness, is potentially problematic and something that maybe hospitals don't want to do. And we experience that in Minnesota, and I'll talk about that in a couple of minutes also. And then of course the funding, and I was definitely blessed in Minnesota to have a great Office of Traffic Safety that held the grant for all the stuff I did. And I ran the SFST, the DRE programs, and the phlebotomy program in Minnesota for much of my career. And they rarely said no when I said I would like to try something, but their question always was, how are you going to pay for it? It was very, very rare that they said, well, we'll throw a bunch of extra money, but it was if you can work within your budget. But then as things started to roll out, they recognized the importance of these things and was able to fund some more of that for me. So that I didn't have that as big of a hindrance, which I know is a great hindrance for a lot of folks. So talking about some of those allied agencies, next slide, please, Aaron. So some of the folks that we need to deal with. Oh, I'm sorry, we have a poll question here first before I talk about that. So do we need to get some buy-in from those associated partners? Do we have to have somebody else outside of law enforcement, outside of our agency, outside of the state, whichever position that you're in to build this out? Do we need to get that buy-in, yes or no? I'll give you a couple of seconds here and we'll close this poll out. All right. I suspect I know the answers. Yeah, we do. I mean, it's something that you probably want to get the buy-in from a lot more people than you think you probably need to get that from. And on the next slide here, I threw a few of those on there, but again, there's a million folks you may want to wrap in, allied agencies and partners that we work with. Maybe it's your Attorney General's office. That's who did our civil portion, our license revocation portion in Minnesota. So they're going to have to deal with it. Is there a problem there? The traffic safety resource prosecutor, because they're going to be your go-to for the other prosecutors around the state to talk about that. If they can back in, they have the power to get that information out and help educate the prosecutors. That's fantastic. Again, your Office of Traffic Safety, even if you are not funded, if you're an agency and just want to start it in-house, your Office of Traffic Safety probably wants to know it, and maybe they can do something resource, be it funding, be it staffing, be it something. Maybe they can help at least a little to help you support that, so you're not really going it on your own. The legislative piece, again, if you don't have the law to back that up, what if legislation is needed? Maybe you need to identify who's going to testify if we need to change the law. Identify some legislators that can write that and back that for you, and then who's going to be there in support of that to testify to the benefits of that phlebotomy program. The public. The publics might see that and go, what are my cops in my town or my county or my state? What are they doing nurse work for? And we can educate them and say, well, yeah, it is a medical process, but again, it's part of that criminal investigation. So we really need to put that limited scope of why we draw blood into the hands of our law enforcement officers. And then a good training partner for sure. You have to figure out where you're going to train and how you're going to train that, and where you're going to get those individuals from, and what your training program is going to look like, and the continuing education that goes along with that. Next. Okay, so here's just a thumbnail sketch of what I did in Minnesota. I started looking into this in 2008. I heard of other states doing this and other agencies doing this and thought, I want to bring this to Minnesota. We had an issue in the southeastern part of Minnesota. Let me choose my words carefully here, from a world-renowned medical network that is housed in southeast Minnesota, that I'm sure you would all recognize the name. They at one point said, we're not doing it. If you need a blood draw from somebody in our hospital for legal purposes, we're not doing it. And I understood, I guess, the argument a little bit, again, wrapping their employees into that criminal case and getting them tied up on stuff. That was probably something that they didn't want to do. Yep, I get that. Part of me said, I don't really get it. It can't be that big a deal, but they said this is our stance. So in that part of Minnesota, which took a lot of trauma cases in from motor vehicle crashes, law enforcement would have to hire a contract phlebotomist. It was basically just a phone number. You call 1-800 draw blood or whatever it was in that part of the state and said, we need somebody. And that medical personnel would come to the hospital and draw it. The hospital didn't have any problem with somebody else drawing it in their facility. They just weren't going to have their employees doing it. So that was one of our first big issues. And that's kind of where we started the program and built it out from there. We held our first training in 2011. It took me a couple of years to find the training partner that could do what we wanted them to do. And then that training's been held annually since 2016. It's been held twice annually since 2017. So again, our Office of Traffic Safety really backed it for me and said, you know what, this is a big enough issue that we really want to start growing the program significantly. So we held 2 classes a year starting in 2017. And roughly now there are 91 law enforcement phlebotomists in Minnesota from about 38 different agencies. So state, local, county agencies all over Minnesota. So again, I rolled this out as a statewide program. Now, that does not preclude, and our statute allows this, and I'll touch on that in a minute, but that doesn't preclude any other officer who has the training, who has their command staff's backing to do that. And in fact, with the State Patrol, we had a handful of troopers who had training in other professions. We had a trooper who came to us after she had spent a significant portion of time as a flight medic. We had another trooper who was a medic in the military, and they said, I am authorized to do that in those situations. So we looked at it and said, okay, that's fine. And we've got a couple law enforcement agencies in Minnesota that have police paramedics. They are cross-trained as paramedics. They are authorized within the law to do that. So the folks I trained, I kind of kept under the umbrella that we'll talk about with the training and the annual training. Anybody else, though, if they fit the law, they were certainly eligible to make those draws. And then we've had over 2,300 roughly draws in Minnesota in the last roughly 10 years. So it started to grow again exponentially with the more and more people we had. So our initial training is an 8-hour online course, 24 hours of classwork at a college. And part of that initial training was 50 draws with in a clinical setting with some instructors, medical instructors watching and kind of supervising those draws. Part of the time that's spent, like I said, finding a partner that could do this. I approached many different colleges. We go through a community college here in Minnesota. I lead the training up to them because they have a phlebotomy program already for individuals who want to go through college, get their phlebotomy training and become a phlebotomist as a profession. So when I approached many of the colleges, I said, here's what I want to do. And many of them said, we have a program, here it is. You know, and it's 3 days a week for an hour a day for the entire semester. And I'm like, well, that can't work with law enforcement. And it can't. It certainly can't work with law enforcement, but that's really not the best way for law enforcement training to go. And I said, in addition to that, we don't need drawn out of feet and drawn out of kids and babies and those types of things. I said, we basically need adults and we need arms. And they said, oh, we can tailor that program for you. And they took their semester-long program, whittled it down to what you see here on the screen. So again, why do we need phlebotomy? What's the importance of that? Next. There. So again, we know that drug driving is on the rise. And again, those DWIs in that case, building that case file is a law enforcement process and not really a medical process. So that nurse, quote unquote, is now being brought into that. Their availability for court sometimes becomes an issue. And the hospital network I mentioned, they said, we're spending money to pay our individuals to go sit in court for a day or 2 or 3, however long it takes, not doing the job we've paid them for. So again, I kind of understood the argument and why they were taking that stance. So those draws don't have to be done at a hospital now with a law enforcement phlebotomist. Next. Okay, next poll question for you here. So does a law enforcement phlebotomist need to be a DRE? And this is one of the questions I probably got more often than not. So while I'm not a DRE or, geez, do I have to go to DRE school first to be a phlebotomist? So there is a common kind of misconception about that. So take a second, yes or no, do they need to be DREs? And then we'll close the poll, take a look. Absolutely. Absolutely hit it on the head here, folks. 95% said no, they do not, and no. In fact, there are many law enforcement officers that contact me and says, I don't want to be a DRE, but I want to be a phlebotomist. I'm like, great, sign up for the class. Let's go, because we need those individuals as well. Now, they work well, they mesh with DREs, and I'll talk about that in just a moment here as well. So next slide. So again, we have those officers on the roadside, A-RIDE trained, out there detecting those drug impaired drivers. They contact the DRE to come in, and we talk about the drug to driving cases, because generally we're talking about phlebotomists in those cases, but certainly in alcohol cases as well. But utilize that DRE to make their observations. If you've got an expedited warrant program, that is fantastic. We have a very robust one in Minnesota as well. And Darren will talk about some expedited warrants here at the end as well. And then phlebotomy, they need to all mesh together. This is kind of the gold standard, to have your officers trained, have DREs, have law enforcement phlebotomists, and have that warrant program. That's really the best way to kind of approach this from all angles. Next. Okay, so why phlebotomy? We're going to utilize those other law enforcement resources. Like I said, now you have an arresting officer, a DRE, and a phlebotomist. Yeah, you've got 3 officers that are involved in the case, but as the arresting officer is working on the warrant, the DRE can work on their drug influence evaluation, and the phlebotomist can be ready to go as soon as that warrant is signed. So instead of that 41 to whatever it was, 90 minutes that I believe we saw in the polling question, we can say warrant in hand, draw the blood, and it can be 4 minutes or 9 minutes. I mean, it can be that quick from the time warrant in hand to the time the blood is drawn. We're not doing any transport. We might all be at the same PD, sheriff's office, wherever we happen to be at the same time, and we can really streamline that process. So again, we don't have to be a DRE. It's a skill that we're going to need eventually, and we've probably all utilized those individuals from at some point in time. So let's get ahead of the curve here and get a fix before the problem becomes a problem. So we know what phlebotomy is, and we know that in the medical field, Many people do it, and it's an everyday occurrence. It's pretty common occurrence. It's pretty simple. Most people don't find it too terribly intrusive. Courts have said it's a little more intrusive than breath tests, so we got to get the warrant out of there. So let's, again, make sure we have all those bases covered. We have those trained individuals. Next. Okay. So in everyday life, obviously done in a number of places, inside and outside of medical facilities, hospitals, et cetera. And that's kind of one of the tenets of this is we got to make sure we're in a clean, not necessarily sterile location, but we can do that. We can do that at our police departments and our booking rooms, et cetera. Certifications really only required in 4 states, and as much as, and I looked again last week, and it sounds like the 4 states, or looks like, are still California, Louisiana, Nevada, and Washington. Their statute says you have to have a certification as a phlebotomist. Many other states say you have to be trained by an accredited institution, whatever, so they require some training, but there are very few states that require an actual certifications or licensure to be a phlebotomist. Many places though require, if I was going to be a phlebotomist as a profession and I want to go work at Hennepin County Medical Center in Minneapolis, they might say, okay, if you're going to come work for us, you need to be certified, you need to have this many training, whatever it happens to be. So it really comes down to the employer in most states saying this is what we want out of the training piece. So when people look back at that and say, well, geez, how do I get certified? And I've told my phlebotomist over the years, if you want to go on to that national certification, there are ways to do that. We're not going to get you there because it isn't required here for statutory purposes. But if you want to knock yourself out, that's incumbent upon you to take that extra step. Next. So ensuring that we're in a controlled environment. I mean, that's OSHA even says that for phlebotomists and nurses, et cetera, down the line here, that we're in a controlled environment. And it is something that we can do, again, clean and versus sterile. And one of the issues we ran into is just having the jails, the PDs, the booking rooms, the locals, whatever that happens to be, aware that you're going to do. We had one phlebotomist that went into a sheriff's office that she had been going into for years, making draws. A change in command, new sheriff, new chief deputy. She was in there doing a draw one day, didn't think much of it because she'd done so many of them there. The chief deputy saw it and went, what's this all about? They decided internally that it was something they didn't want to do. The new command said, we don't want to have those done in our facility. So they made an internal policy, and that's fine. That's completely up to them. We just got to change our program now. And maybe the deputies or the locals will take them to the PD instead, and we can do those draws there. But just make those people aware. It's like, here's my training. This is what I've done. I'm not just making this up, coming out of left field that I'm going to make these blood draws. I've got the training, I've got the experience, and we can do this, do it the right way. So we talked about clean versus sterile, and thinking about other options if we have somebody who's not cooperative. Talk about those stable platforms. Some of these slides come right out of what I talked to our phlebotomists about. So things that I tell them to think about, but versus, again, things that you'll want to think about as you roll your program out. So we're doing those at a sheriff's office or police department to make sure we have that stable platform. So here is our Minnesota's statute, implied consent statute, that talks about the testing. And I highlighted a few things on here. Phlebotomist has been there. It was there when I started my career in 1988. Phlebotomist was a authorized individual who could draw blood for these purposes. A handful of years ago, maybe halfway through my career, the early 2010s, we had a number of cases that were challenged because those individuals in maybe medical facilities weren't technically phlebotomists. They were trained to draw blood, and they've done it thousands of times. Maybe they were called medical techs, maybe they were called lab techs, whatever it happened to be, but they weren't by definition phlebotomists. So, and it wasn't because of law enforcement phlebotomy. Long before we started even thinking about that, there was legislation that we added or other qualified person into the statute. So not only once, but twice, we've got the law enforcement phlebotomists covered because they technically are coming out of their training a phlebotomist. And the school will attest to that and say, nope, they are a trained phlebotomist. But even if the argument is, yeah, but your class is shorter than the typical, okay, we want to discuss that, that's fine. We've got that kind of fallback of the other qualified individual. And then also in that statute, when we talked about the liability, nobody is liable unless there's negligence, just like everything else in law enforcement. Unless we are negligent in how we are doing it, we are not liable for anything that may happen. So right in our statute, it talks about that. So when I would get those comments about what about liability, right in the statute. It is expressly stated there is no liability, again, unless there is negligence. Next. So I talked to my phlebotomist about what is in our kits, which is probably pretty standard for most everybody. You get the 2 tubes with the powder and the needle, et cetera, those things that are in there, an iodine swab versus an alcohol swab, because then there's the argument that you're putting alcohol into this sample. So we got to make sure that the site is clean with an iodine wipe that comes, again, in the kits that are provided to law enforcement in Minnesota. And then I talk about some of the paperwork, because now it's different. Instead of just signing where the law enforcement officer signs, now they're going to sign where the phlebotomist, nurse, whomever did the draw signs. So just make them aware that there is some differences. So things that I would tell them, hey, here's some things that aren't in the kit. And part of the grant funding that I had not only provided for the training, but also provided a kind of a starter kit. I'd get them a little bag. We make sure there's a couple of the lab, the state crime lab kits that are in there. Our BCA, our Bureau of Criminal Apprehension, provides those to law enforcement. I'd purchase tourniquets. Every agency's got the bandages, the gauze, the tape, those types of things, and the gloves, and we can throw those in there. And sharps containers, we get those for the individuals as well. And we kind of get them here. Here's your kit. So now when you get called, you can grab your phlebotomy kit, and into the PD, the sheriff's office, you can go, and you've got all the stuff that you need to perform that draw. So another thing that I talk about is documentation. In the slides that you're going to get, in the handouts that you're going to get, there's a couple of samples of kind of maybe ways to phrase it, because we write law enforcement reports and we do that all day long and we're good at it, but this is something different. And until we get used to it, we got to think about some of the things that are included in there, and you can see them on the screen here. I'm not going to go through them one by one, but it's stuff beyond what we typically would expect. And until you get good at it and get used to writing those reports, just it helps to have a little cheat sheet to make sure to cover those things. And again, a couple of samples in the slides that you are going to get that you can take a look at as well. And then I required my phlebotomist to submit an activity log annually. I told them I want to see a log of all your draws to show your proficiency. We want to be able to go into court. We want to be able to testify, yes, here's my level of training. This is the training I had, but here is what I have done since I've gone through my initial training and my annual requalification trainings, et cetera, and can show my proficiency in this. And for those that have been in the DRE world for more than a couple of years, before we had the national data tracking site that we could enter our evals on, this was a typical DRE rolling log. And I, like a good police officer, I just stole it from somewhere else and made it mine. So that is something, if you would like that, we can certainly get that out to you as well. It's just a fillable PDF, or a fillable Word document, I believe is the one I have to go through and just put some of the stuff on there. But again, think about the things you might want on that log, create your own, whatever you need to do. But I ask for my phlebotomist to send me that every year. So our annual research requirements, so you saw the initial training requirements, but annually we would require 4 draws and then some classroom work. So once a year, I would bring everybody back to the college, and they would do a half day kind of educational and something else, maybe show them about drawing out of the back of a hand, because that's something that is commonly used if a vein in the arm can't be found, et cetera. So they would update them on some stuff and maybe show them some new techniques and work with them. And then they would witness those 4 draws for that kind of continuing education. Again, not a certification, but that continuing education to show their proficiency and show their skills. So finally, here's your 5 takeaways, and there might be 10 or 15 for you individually, but here's probably the 5 biggest. Make sure your statute has some language that addresses this, whatever that happens to be. Phlebotomist, other trained personnel. Kind of look at what you've got in your statute now. It's pretty likely that you probably have something that might qualify, that you could fit a law enforcement phlebotomist under that umbrella. If not, then think about, what do I need to do to maybe bring that about? I've got prosecutors, attorney generals, but all those allied partners, whoever they happen to be. We talked about the public. We talked about our offices of traffic safety, et cetera. Find some place to do the training, wherever that happens to be. And again, we do it out of a college, and maybe you'll have an ambulance crew do it. Maybe a hospital will do it for you. From top to bottom, we'll do that training for you. But find those things that, and the reason I liked having the college do that, because again, they had the program, and I could say, it's not me making it up. I never even went through the training myself. I coordinated, I put it together, I kept it moving forward, but I really have no desire using a needle and drawing somebody's blood. So I would use my own individuals to come in that I helped train to come in and take those blood samples for me. But because we had that, we can say, look, we are under a greater umbrella than just law enforcement teaching law enforcement. That's sometimes a lot of things what we hear. Well, just cops telling cops what to do. Well, no, we actually have some college level coursework here that we include in our training. Develop some policies and standards. And again, if you'd like to see any of that, you've got my contact information. I can send some of that. We've got some of those examples in the toolkit as well. So if you take a look at that, you'll see some of those things individually in there. And then we talked about that data and that documentation and that data collection. You want to make sure that we can track that stuff. And if somebody funds that for you, they're going to want to know. They're going to want to know what their money is going to. And it's nice to be able to have that at my fingertips. So again, back to those, the law enforcement phlebotomy toolkit from NHTSA. I won't go through it again, but you can see the stuff on the screen here that is included in that toolkit and some of the things that kind of helped me along when I went through the program, and some of the things that I found out from other programs. I didn't really invent anything on this. I just had to put it together to fit what worked best for Minnesota. And this was, I kind of wished I had this, because this is a great tool to get you on the right path to make sure you can check all the boxes and move your program forward. So right now, if you've got any questions, I think I saw a couple of pop up in the chat.
Yep, I'm glad to read this one from Christine Childers. In states that require certification, does this require that the officer take the traditional phlebotomy course, or can officers receiving the condensed law enforcement version be certified?
Well, honestly, I will tell you, I did not look into what those states require as part of their certification. I would bet that it has to be an accredited. I would bet it would have to have some sort of continuing education, which again, we built that into Minnesota's program. I don't know that it says certain hours, et cetera, but again, for those 4 states, that's in statute. So whatever your statute says, you certainly have to follow that. So I'm sorry, I can't speak specifically, but just know that there is some statutory requirements in those states.
Awesome. Thanks, Don. We have another one from Thomas. Have you had any phlebotomist either removed or disqualified from the training or program? If so, what did you encounter?
Removed, I guess the short answer would be yeah. The long answer would be, well, just because they didn't complete the training. And it was more of a voluntary withdrawal. Hey, I can't make the training. I'm not interested in doing this. I'm not that confident because I don't do enough of them. I never had anybody that had to be removed for cause, doing something wrong, not following the protocol, not turning in their data, anything along those lines. So I never had it as a disciplinary type removal. It was just more, now I'm into investigations and I don't have that much opportunity maybe, so I'm just going to let it go and let somebody else take the spot. So that's kind of how it was addressed, at least in Minnesota.
One from Mallory. In court, is there ever a concern about an officer drawing blood being a conflict of interest?
And that was another one of the questions or the things I got initially from our Attorney General's office. They're like, so you're going to ask him for blood and then you're going to take the blood. I'm like, yeah. And they said, well, doesn't that sound kind of coercive? And I'm like, well, I don't know that it's much different than I'm standing here going to run the breath instrument as well. I mean, I'm not hovering over them with a needle saying, say yes, or I'm going to stick you anyway. I mean, I'm not really sure where that, I kind of understand the thought process, but part of me was like, okay. So initially what we did in Minnesota, we wanted to limit it to the number of prosecutors that would have to deal with it, the number of agencies. So we started small, and again, in one portion of the state, we kind of concentrated everything there. We let it kind of grow for a year or two. It's like, okay, I told my phlebotomist initially, don't draw on your own individuals, because that was at least a concern by some people. We didn't have a whole lot of defensive bar pushback. So after a couple of years, I talked to them and say, you guys getting any pushback? You hearing anything in court? And most of them were like, no, not really. I'm like, okay, then go ahead and you can start drawing them on your own. But they understood from the beginning, that's like, okay, let's take some baby steps and not screw this up for the future by getting some bad case law. We'll ease into this. And then after the first couple of years, we were able to roll it out to all the rest of the state as well.
Got it. Thanks, Don. And then we have 3 more questions here from David. Do you have any recommendations for the best type of kit container for LE phlebotomist? Some of us use a tackle box, but it doesn't seem like it's the best option, especially for being stored within a patrol vehicle.
Yeah, and I just bought actually small soft-sided tool bags that I found at local hardware. So I've seen backpacks, I've seen tackle boxes, I've seen a lot of different things. And I guess I don't know that I have a best practice suggestion other than you should probably get them something that has the stuff in there. In fact, those soft-sided tool bags that I would give out, saw one of my phlebotomists come back for an annual recert, and he had moved his into a tackle box on his own. He had bought a kind of a more hard-sided because he thought, well, bouncing around in the trunk of the car, I want to make sure nothing gets dinged up, which knock yourself out if that works best for you.
Got it. And then just reiterating that the link for the phlebotomy toolkit is in the chat here, and we will follow, responsibility.org will follow up to everyone on the webinar today with all these links and a bit more information, including the recording. I think the last question is, from Nicholas, any liability suits arise from LE blood draw?
As I said, we never really had any defense challenges at all to any of it. I've had a couple of phlebotomists say, yeah, the judge kind of looked at me sideways and said, you did the draw? Yeah. Huh. And kind of went, well, I never heard of that, or that's odd. But with an opportunity to explain, look, here's my training, here's my experience. We've never had any major pushbacks, never had any significant case law that we've had to deal with, knock wood. And we've got a pretty good defense bar in Minnesota that would, I mean, if they felt that it was challengeable, I would suspect that we would see those challenges we've never had. And I would imagine some states have. We just never had that experience in Minnesota.
Got it. Okay.
Hey, Leslie, there was one more that just popped up from Thomas that might be good for just to cover as our last one.
Got it. I can't see that one, Darren.
Okay, I'll just read it. It says, we are currently looking into starting this type of program with our agency. What advice would you give or place to start from?
Well, I guess the step one would be to identify the partners you're going to end up having to work with downstream. Be it if it's your city agency or your city attorney, your district attorney, whoever the prosecuting entity is, talk to whoever does your license revocation hearings, because they're going to want to know that this is coming, certainly, and they're going to want to be prepared for it as well. Talking to command staff. I think really identifying partners is probably your biggest first step. And some of those partners may come along with funding. You might say, I'm going to contact the AAA, or I might contract MAD in my certain area because they want to support those types of things, and maybe they can assist with funding. But I think identifying those partners is probably the first step. And then once you start to get the buy-in and say, okay, this is something I think that can happen, I would say your next step is probably looking for a training partner after that.
Jennifer?
I would add that the toolkit is there to support you every step of the way. And again, we'll have technical assistance and financial support available through an application process in the near future.
Absolutely. Yeah. So, for any of you that are looking, a lot of technical support through the National Highway Traffic Safety Administration in making this happen. I know we're at the top of the hour, but just wanted to see, for those that are diehards and will stay with us, what authorization do you need for blood evidence in your state? This is a multi-pronged question here too, because you might have all, or maybe just one. So if you could take a quick second to address that, answer those questions, and we'll close the poll. Good. Interesting. 55% still voluntary. That's a lot higher than we anticipated. So that's good information for us to have as we look at. As you look at how you get those blood evidence pieces, one of the things that we did want to just cover here at the end is the electronic search warrants around the state, around the nation, looking at authorization either legislatively, court orders, or both, and what you have in your own state. And then also through responsibility.org, we have a guide to implementing electronic search warrants. And this program really, from soup to nuts for electronic search warrants, this was built through with the Justice Department and Management Institute. So, and really looking at how do we help states build electronic search warrant systems. So even if you don't have one, or you do and want to enhance it, this guide and information could be very instrumental in helping assist you with that. So I just would like to have you join me in thanking our amazing panelists, Jennifer Davidson from NHTSA and Don Morose, for sharing their experience with us today. And I would like to thank all of you who joined us on today's webinar. We had over 372 registrants, over 200 on the call. We hope that you'll be able to listen to the recording. And I want to remind everybody of the incredible grant opportunity and technical assistance that you can get through the National Highway Traffic Safety Administration. Great partners. We appreciate their support and their assistance. And as noted earlier, this recording will be available. We'll have the links to the toolkit, as well as some additional information that will follow. You know, as an organization, as responsibility.org, our eye is always on the ball about alcohol impairment and drunk driving. But we also feel how important it is when we look at the data to make sure that we're looking at it 360 and not just maybe from one perspective. So that's why today we bring all of these resources together in partnership to be able to address these things. To learn more about some of the multi-substance impaired driving, you can go to stophrid.org. And I think if I move to the right, you can see Stop High Risk Impaired Driving. It keeps backing up behind me. But on behalf of responsibility.org and the National Alliance to Stop Impaired Driving, the National Highway Traffic Safety Administration, Don Morose, we want to thank you for all of the things that you do to improve our road safety. So thank you, and that will conclude our webinar.